Hello, and welcome to today's live discussion with Quality Interactions. I'm Michelle Corton Brown, and I'm delighted to be here with my friend and colleague, Dr. Joseph Bentoncourt, First Vice President and Chief Equity and Inclusion Officer at Mass General Hospital. This is our last session of a series, and as we begin this session, we're going to focus on recovery and reopening, because that's what many of us around the country are really addressing. So, Joe, welcome. And
Thank you. Good to be here.
Maybe start by asking how your week's been.
Yeah, it's been another kind of exhausting one. I think again to this old enemy that we're attacking yet again, racism. I think we're trying to bring that same fervor and kind of sense of urgency. There was a quote here that's been kind of feeding my soul this past week from Martin Luther King. He said, "We are now faced with the fact that tomorrow is today. We are confronted with the fierce urgency of now. In this unfolding conundrum of life and history, there is such a thing as being too late. This is no time for apathy or complacency. This is a time for vigorous and positive action." So when I start to get tired, I read that because I think that's the motivation that we all need. Clearly, as it relates to this newest battle against racism, it's important that we clearly understand that people's minds, the complacency of racism denial, as Kamara Jones talks about, will settle in very soon. And so trying to grab as much land as we can right now and get as many commitments as we can, that's been what I've been focused on. And it's been hard work. We've made a lot of progress over the course of the week. I think I mentioned last week the drafting of a 10-point plan that had a whole series of different components to it. We've advanced that. We're socializing it now with our community of stakeholders, with our leadership, and we plan to make some real strong commitments in the next couple of weeks. The plan covers a lot of different areas, including reviewing all of our policy, and these aren't set in stone yet. We're reviewing these, but I just want to give those who are on the line the portfolio that we're thinking about, evidence-based over years. Some of these kind of easier wins and things that we were working on. Some of these promises that we've made for decades that we've never delivered on, and some of these big, significant, transformational efforts. And they include things like reviewing all of our policies and practices for structural racism, creating a reporting and reconciliation plan for incidents of racism, discrimination, microaggressions. Training is a big one, right? A training pathway on racism, implicit bias, cross-cultural communication. Really doubling down on healthcare disparities, so ensuring equity in access to and delivery of care. I think we focused a lot on measuring our quality of care, but we want to do a better job of measuring access. How well are we doing in people being able to access our services? What communities could access our services? How easy or difficult it is, and really measuring that. Major initiative on eliminating racialized science and medicine. There's still a lot of things that we do, like I'll pull up a lab on my patient and there'll be a kidney function, a renal function figure that'll be pulled up, and across the country there's what we call an adjustment for African Americans. It says adjust this number by 1.1 African Americans, and people have been trying to say for years that that's based on faulty science and racist science, and it's not legitimate anymore. There are better ways to not adjust for African American. What does that even mean? And so that's one, and that's one of a whole series of them. So I think that's somewhere we're driving. A big transformational one, quite frankly, is living wage, more support for kind of educational development of our low-wage employees and making sure they can get their healthcare here, and we facilitate that. Diversity, an old word that has never been executed at the level that I think any of us would be proud of, and how do we bring rigor to that with goals, timelines, accountability, and transparency? How do we really kind of hypercharge that and hold our leaders accountable for performance and execution? Another one is, there has been a reckoning on policing, and I think we have a responsibility to look at our work around security. I think we have an incredible team here. I get, just so people know, every time there is an incident that's reported to police and security related to any issue around racism, sexism, and the like, I get that incident report. And then we try to, address the key factors. So they do great work. We want to build additional metrics. They already have done training on implicit bias. Maybe we want to build on that and do some more training with them. So wonderful group, and I think, but I think this time calls for that. That's something that we're going to do. A big campaign on anti-racism, equity, and inclusion, and really leveraging our platform as a thought leader to advocate against racism in all of our society and all of our institutions. So those are kind of a sneak peek of the 10 points that we're trying to engage in. Again, they're a mix. This, racism wasn't created overnight. It's not going to be solved overnight. Structural racism takes on a lot of forms. It camouflages itself, so you really need to hunt it down. And I think that requires diligence and deliberation. But people are energized, Michelle, like I've never seen before in my lifetime. And again, this is a time where we have a legitimate case study for being inattentive to these factors and a real buy-in. I would argue real kind of moral reckoning for people who didn't understand the types of things you were dealing with every day and understand them better now than ever before. And so we got to get those commitments quick before other things occupy their time.
Well, what you've described is very comprehensive and feels very different in terms of establishing metrics and dashboards and accountability.
Yeah, it is, and metrics are just part of it. I mean, I think it's commitments that, make no mistake about it. This will require resources in a time where we are financially very constrained, like all healthcare institutions around the country. But at the end of the day, this time, this is a triumvirate of crises, right? COVID, racism, and financial instability. And I think, but this is a time that really calls for dramatic action. And so it will be we hope to, fall on a real comprehensive portfolio of activities that allow us to, be more explicit around driving out structural racism and using our platform to really be anti-racist in everything we do and advocating for anti-racism outside our doors. And so off we go. And, we have a lot of positive energy, but the commitments are still kind of the big commitments are coming. And it's just tilling that field, just preparing that environment, socializing, engaging. But the good news is that I think level of engagement and appetite to go big here is in front of us, and we need to take advantage of it here and everywhere.
Well, speaking of going big, one of the elements you described was training. I wonder if you might delve a little deeper into what.
Yeah, no, absolutely. Training is important. We've been committed to training for a lot of years. And I think we've always said, Michelle, that training doesn't solve everything. Training needs to be one of a portfolio of things, a biosphere of things that facilitate a series of actions. That being said, I do believe what you do by way of training signals your values, right? If we have a lot of training on patient safety, it's a signal to me that patient safety matters, right? Hand washing, fire safety, like some of these are compliance, but some of these are, places the organization is trying to go. Now, again, training does not behavior change make alone. You need to build that biosphere around it, but it's very, very important. And especially, I think, as people have come to realize, boy, like we don't know a lot about, a lot of people don't know a lot about the history of racism in this country. A lot of people don't know how to, understand implicit bias. A lot of people don't know how to really build trust in cross-cultural situations. And I think in so much as we are deliberate with what the types of things we've been talking about over the years, a learning pathway that's built over time, our commitment is not going to be a one and done. What I'm really doubling down on is a 5-year learning pathway, mandatory, discipline specific, practical actions, tools, skills, all the things we've always talked about, and just again hypercharging that, but making it mandatory for everybody, really kind of being more rigorous. But it will require all the supports, I believe. But again, racism, implicit bias, microaggressions, upstander, bystander, cross-cultural care, communication, building trust. Those are kind of the things we're thinking, and they're going to be very important. And I mentioned, implicit bias. Implicit bias isn't just for doctors or nurses. I mentioned, police and security as well. I mean, this is something that is a human phenomena, and it impacts all facets of the way we engage with each other. So it's important that we think about it in those ways, not just for clinicians. So that's where we're headed with training, and I think it's an exciting time. And again, I think this is a time to really get people to stand behind what they're saying and feeling.
Great. Well, let's turn back to reopening and recovery in COVID. So, might you share a bit about what you're up to, what initiatives you're undertaking as part of this reopening and recovery stage?
Yeah, so again, we're a big country, and this state where I am, we're very lucky because we have our numbers are very low, and our numbers of new infections by day is some of the lowest in the country. And this pandemic does hit in waves, and the waves are bigger when you're not following the science, if I'm to put it in a politically correct fashion, or an apolitical way. And ultimately, I think we've had the good fortune of doing a lot of things that we thought were important. And so our numbers are down. We have maybe under 50 patients with COVID in our hospital. And so we're reopening. So let me walk you through kind of the thought process here. We're breaking up what we're doing into 3 areas, right? Peri-COVID, which is what we need, it's a Venn diagram with kind of 3 circles. One is peri-COVID. What do we need to do now as we are still in the midst of a pandemic? We're out of the surge here, but what do we need to do? Number 2, the second circle of the Venn diagram is reopening. How do we phase in reopening in a way that's, and again, this is equity across the peri-COVID phase, phased reopening phase, and then finally in the last Venn diagram, the last circle is what have we learned that we should apply immediately to create a better healthcare system from COVID. So those are 3 Venn diagrams. Equity across the peri-COVID phase, phased reopening, and application of learnings. And so as we think about peri-COVID, there's several things that we have done. Clearly, we have developed metrics, surveillance metrics in our hotspots to very quickly be able to tell if there's an uptick, right? So in the peri-COVID phase, that's really critical. And I think and as we do this, continuing to message, communication. So for example, we just got some data that showed that there was an uptick in the Latino population, but it was younger people. And that is worrisome but important information. So now when I do my twice weekly videos in Spanish, I'm able to tell people, look, we need to encourage everybody, young or old, to act responsibly. And please know, if you're young, ultimately you're putting your family members at risk. It's going back to that message. Now, that's quite upstream. We haven't seen the downstream impact of that yet. So we're not seeing more beds filled. We haven't gone to the ICU yet as we monitor, not only the kind of inbound, but what's happening inside, right? And our inside numbers, that's another part of our surveillance is, we're tracking emergency room visits by race, ethnicity, and COVID. We're tracking admissions by race, ethnicity, and neighborhood from COVID. And we're tracking ICU admissions by COVID. And we're tracking testing by race, ethnicity, and neighborhood, testing results in COVID. So this is our kind of dashboard. And the hope is that the idea is that we will react quickly in this peri-COVID phase to anything we see and be able to put back in place some of the things that we stood down. The second is on reopening. We are encouraging people, I think we've talked about this, we're encouraging people to come back. How do we do that messaging in a way that's multilingual, culturally competent, and delivered by trusted messengers? With the important notion of the idea that the patients that I'm caring about, or as it relates to equity, are the ones that we really, really need to come back. And I've said this before, some of my patients, minority patients with diabetes, I see them normally every 4 months. I now haven't seen them for 6 to 8 months. We really need them to come back. And on top of that, we need them to come back at a time where they're quite traumatized, because they likely, and polls are showing this, they likely were either themselves or had a family member impacted by COVID. There's some polls, Washington Post had a poll that looked at, that surveyed African Americans, Latinos, and whites about have you or a family member been impacted by COVID? The numbers track exactly what the epidemic tracked. So, these are people who are scared, they're traumatized, they don't want to come back. We also, around reopening, are tracking, we're doing a lot in virtual, And we understand there's a big digital divide. And so we're tracking how are we doing in virtual visits by race ethnicity to see if we're leaving people behind, which we know we are, and we need to do better. So, you know, a lot of my virtuals, quite frankly, have been on telephone, really true telephonic follow-up, as opposed to using Zoom, which I'm able to use for some of my other patients, or Doximity. So, you know, we're tracking that. We're into making sure we're not leaving people behind. And if we are, what are we going to do to make sure they don't stay behind? And so those are the things around reopening. It's messaging, tracking who's coming back, reaching out directly. And in some of my messaging I've done, it's telling people, don't wait for us to call you or to get you an appointment. Call your doctor, call your healthcare system, call your health center, get an appointment, empower yourself, call. That's an important part of this message. And then tracking all those reopening and virtual visits and the like. So those are kind of some of the key areas that we're focusing on. And I guess we've really tried to get people to be very deliberate in thinking about equity in all efforts related to reopening. That discernment, that deliberate kind of challenge to say, what are your 2 slides as you're presenting this around how this reopening is going to impact vulnerable populations? And we're trying to create some discipline, organizational discipline around equity, so that it's not just me kind of knocking on people's doors saying, hey, did you think about equity? Hey, did you think about equity? Oh my gosh, I really care about equity, but I didn't think about it. No. I'm going to challenge you now. If you care, especially in this time, I need you to think about it. And if you have questions, you can ask me, but I need you to have that responsibility. And then, you know, the applications of learning are a lot. I mean, I think we've covered a lot of different things that we've learned. Equity in all efforts, you know, equity in all dashboards, really thinking about equity in future emergency preparedness activities, increasing diversity system-wide. So these are a lot of the applications of our learnings that we want to deploy. I mean, COVID shed a lot of light on, you know, what it means to not fund your public health infrastructure, to not have language services, to not have trusted messengers, to really allow these gaps in how we communicate with people, you know, the skills we have in communicating with them. It has unearthed a ton of gaps that we've talked about here over the last 5 to 6 weeks. And, you know, really where the rubber hits the road is, are we going to take those learnings and do something about them? Are we going to fundamentally leverage what we've learned to change our healthcare system? And again, I think as we've said, we have the best case study to secure buy-in that we've ever had in my lifetime. The economic impact, the life impact, the costs, you know, all this, I think, wraps up very neatly into why we need to be way more attentive to equity, to cross-cultural care, and to all the things that we've been so passionate about over the years. And I think that's a real important opportunity that we need to leverage immediately. You know, so that's part of the journey that we're on now. And I'm excited about it. I mean, I think it's hopefully a new conversation, but you know, the proof is in the pudding. We'll see. We'll report back in a month and see how we did. You know.
Right. Well, it's interesting, Joe. We here in Massachusetts have seen our cases go down dramatically, as has been the case for a number of other states. Yet we know that California and Texas and Arizona and other states are just beginning to climb that surge. So I'm wondering if you have any advice for some of those states, some of those health professionals that are tackling this anew or in a advanced way in these weeks.
Yeah, and I feel very strongly about this. And I've given this a lot of thought. The single biggest, I think, challenge for us is how this virus has been politicized. And that's not something that is easy to handle, easy to manage, and is something that's very difficult for us as caregivers. So if I were in a state like any of the states you mentioned where the numbers are increasing, and I was a healthcare, somebody who worked in healthcare, I believe it's very, very important that we raise our voices about what we are seeing in the hospital when these surges kick in, right? And really communicate that this is not about good or bad. This is not about red or blue. This is about people, dying and not being able to breathe ultimately. And I think we need to do 2 things in our messaging. Number one, we need to give people a real window into what suffering looks like inside the hospital. I think people saw a lot about the healthcare heroes and all, the things. they need to really understand what that suffering looks like. And number two, we really need to connect it to this can be you, this can be your family, this can be your grandmother. Um, Healthcare professionals really need to fill this void. We really need to stand up in an apolitical way and say, politics aside, let me show you what I'm seeing, and let me tell you how this could be your grandmother. Nobody is immune to this. And so your behavior is, puts everybody who you love at risk. I think that's one. I think second is the types of things that need to be done to impact the surge. What we learned here, we talked a lot about the inbound, the capacity, what we do within our four walls. Preventing surge is all about what happens in the community.
Mm-hmm.
You could gear up and sit here and just be waiting,
Right.
and you are wasting days where you could be trying to mitigate spread by messaging, by giving people the tools to protect themselves, masks and the other, by providing, making sure that people are able to isolate if they're positive, like that. We talked about contact tracing, but those things are really, really critical. And obviously, having testing, broadening your testing criteria, being able to identify hotspots. So it's less in these surge environments and what's happening in these states. Your capacity is your capacity. Have some teams building up your capacity and being ready, but you really need to go out in the community. We really now know, Michelle, what are the perfect storm ingredients. They are densely populated. They are crowded housing. They are people in kind of small environments who aren't wearing masks. They are not wearing masks in general. They are public transportation without masks. I mean, we know enough. So in any of those places, you should be able to look around your communities and say, what community fits those profiles? And more likely than not, it's going to be communities of color. They will again be the canary in the coal mine in many of these states where this is happening. So, and I think really thinking about all things cultural competence on the receiving end as well, and also on the outbound end, the messages, everything we talked about, the messages, the communications, what you're doing inside, being ready to care for diverse populations, all that stuff, standing up, all the stuff that we've talked about over weeks. I think that's what I would encourage. With a lot of lessons learned here, we've been very public and transparent with him. Use them now, because this wave is hitting places that are very diverse. Florida, California, Arizona, a lot of Latinos, a lot of African Americans, a lot of Native Americans who've been hit incredibly hard. All the stuff we talk about is incredibly important in those states.
Absolutely. That's very great. That's very good advice. You mentioned telehealth as being a vehicle that you're using to reach out to patients. Any thoughts about how cultural competency impacts that interaction?
It does, and I think fortunately we've created some tools in years past that focus on telephonic interaction. Working with health plans, for example, knowing that they weren't seeing people live. And boy, those things are so applicable now because our communication is almost exclusively virtual with people. And so, yes, there are tools that we've talked about around building trust, around playback, around how to manage different styles of communication that are now more incredible than ever before, because you don't have the cues if you're on the telephone with somebody with their body language and the like. And so I think health plans and our work with in that space, I think, is particularly helpful now, and some of the things we've been doing with those groups to healthcare more broadly, because those skills are very, very needed. Your ability to build trust telephonically is very different than I look you eye to eye and I demonstrate compassion. So absolutely, as I think about our portfolio, I think it absolutely applies, and it's especially critical because the communication is more limited in the virtual setting.
Great. We're reaching the top of the hour, Joe, so I wanted to just give you an opportunity if there were any sort of last thoughts you wanted to share, particularly around reopening and recovery.
Yeah, I mean, I think I wish those in states where the numbers are going up the best, and please feel free to reach out to me if there's if there's particular advice I could share. Happy to do that. I think these last bunch of weeks for us have been great conversations, real interesting journey. Man, have we covered a lot of information and twists and turns. I really, really hope that we can apply the learnings of COVID to create a better healthcare system. We're not out of this yet. We still have, a fair amount of time that we're going to be in this pandemic. But applying the lessons of equity of cross-cultural care to reopening and recovery are going to be really, really critical, or we are just going to once again relive the set of factors that lead to disparities yet again and yet again. If people aren't able to come see us, if we're not able to open equitably, that's the real peril here, and I think we have a chance to do it. So I'm hopeful, but as with everything, we need to be good stewards and good champions of this work. We need to inform it, and we really need to raise our voices and our leadership. And my hope is that we can do that. And I think this portfolio, the portfolio that we care so deeply about, is really important in this journey.
Totally agree. We've gotten quite a bit of really positive feedback from participants in this live discussion series. And one of the things that came up for them is question of training. And so I wanted to share that we have a resource, an online resource for training. Quality Interactions, along with National University, launched an online certificate program on cultural competency. And it's a bundle of 7 of Quality Interaction e-learning courses, along with 2 master courses taught, one by Dr. Joseph Bentoncourt and by Dr. Alexander Green, and a directed study by Dr. Amelia Grillo. And that bundle together offer fully accredited CME credits, as well as 1 CEU credit from National University. And we invite you to head up our website to learn more. But we've heard from a lot of you that you're interested in getting skilled up and supported around how to play your individual role in improving health equity. So I just share that as a resource to you as we close out. So I thank you for joining us today. Thank you for participating in the entire series. We've gotten wonderful feedback, and it's been a great opportunity for us to connect on the important issues of health equity, particularly in light of this pandemic. Joe, I thank you for sharing your wisdom, your frontline experience, and just the depth of your understanding of our aspiration to have a more equitable health system for all. So thank you, Joe.
Yeah, it's been a pleasure. It's been great to have these conversations in kind of a relaxed format and just kind of being able to reflect and share learnings. And I do it with all due humility, but a lot of conviction. And so we keep running.
Indeed.
Thank you all for having attended any of these. We appreciate it, and we value your partnership in this movement. So thank you.
Thanks. Have a good day.
Okay. Good luck, everyone.